vocal cord granulomas, polyps, vocal cord palsy, and penetrating neck trauma. There's clearly not enough time to go into all of them in great detail, so we'll touch upon them all, but please read around them all. So if we start with vocal cord granulomas, so vocal cord granulomas are benign lesions. They tend to start in the posterior third of the vocal cord, near the arytenoids, and they tend to form as a result of irritation. So this can be trauma from the opposite vocal cord. That's particularly when you're singing, shouting, coughing, and other common causes include acid reflux and prolonged or traumatic intubation. Granulomas are often pale pedunculated masses found on the medial or superior edge of the vocal process of the arytenoid cartilage. However, they can also be sort of deep red, lobulated and sessile. So patients with granulomas, they can be asymptomatic, or they can present with dysphonia, some discomfort of the throat, characterized by throat clearing or a foreign body type sensation, and dyspnea in bulky lesions. Differential diagnosis would include sarcoid, carcinoma, and papillomas. Right. For investigations of these lesions, you should always include flexible laryngoscopy, some speech and language therapy, and assessment, and stroboscopic assessment, with the possibility of a microlaryngoscopy and biopsy. These lesions can often be diagnosed clinically. However, often you need to exclude malignancy, hence the need for a microlaryngoscopy and biopsy. I've included a link at the bottom that will go into a bit more detail about stroboscopy. Right. So yeah, as I said, the main thing is you need to exclude neoplasia. You need to make sure that this is not a malignant lesion. If there's any doubt, then the plan is to biopsy it and confirm your diagnosis. And once you've done that, your treatment is based on treating the cause. And so for a medical management of these things, we'd look at using a proton pump inhibitor, anti-reflux medication. Some places have used inhaled or oral corticosteroids, but there is very little evidence available for this. And this is not something that I would use in my practice. Speech therapy and voice therapy is also very important. In contact granulomas due to voice abuse, you can also use Botox, and some papers have reported 70–77% success rates. The idea being that you induce some paralysis, you stop that trauma and give that area a chance to heal. For cases that have failed with medical treatment, you can move on to surgical resection. And this is possible, however, there is a chance of recurrence with all of these treatment modalities. So we're going to move on to vocal cord polyps now. And in the first case, it's important that you're able to distinguish between a vocal cord nodule and a vocal cord polyp. So vocal cord nodules are epithelial growth that cover the membrane. They're kind of like calluses. There's a thickening of the vocal cord lining, and this is usually as a result of vocal cord abuse. They're often quite small and hard, and they're usually bilateral. On the other hand, vocal cord polyps are polypoidal growths of the vocal cord. They appear to be a blistering of the cord lining, and they're often as a result of vocal abuse, chronic laryngeal irritation, and they often look like a blister. You can have a stalk, and they are often unilateral, but not always. They can be bilateral. So this diagram here illustrates the differences between the two. You can see the nodules look like a hard, small plaque. They look very firm, whereas the polyp itself, it's like a blister, and it's broad-based in this case. So the polyps themselves, as I said, they tend to involve the free edge and hence lead to the voice change and the issues there. The polyps themselves can be fibrotic, vascular, or a mixture of the two. And as I said, they tend to be as a result of vocal cord trauma and voice abuse. So investigations are very similar, like other laryngeal lesions. You're looking at clinical examination, particularly of the head and neck region. You want some flexible laryngoscopy, see the lesion, stroboscopy to assess the voice and the impact this is having on them, and then you want to think about a rigid endoscopy and biopsy. So in terms of management, you've got your sieve, you've got your non-surgical and surgical causes. So non-surgical, you want to remove the risk factors, and you've got to address the underlying cause, as the risk of recurrence is high. So you want to speech and language therapy, and as with all laryngeal pathology, you want to ideally stop smoking. So surgical intervention, we're looking at excision, and that can either be with cold steel or a laser. If you're going to use a laser, you've got to factor in the thermal effects as well, as that will cause further irritation and could potentially exacerbate any recurrence. So pedunculated lesions, you want to look at retracting that, excising them, and you can put a small flap and amputate them. For more sessile, broad-based lesions, you want to raise a small micro flap to remove the lesion. So I've put what is your approach, because I think it's important that you have a broad knowledge of the options, but then you can talk about what you would do rather than quoting textbook. Have something that is your personal opinion or the practice in your unit. So I'm going to move on to vocal cord palsies now. So we've got history. You've got to think about your symptoms and associated symptoms. So your symptoms include hoarseness, noisy breathing, loss of your vocal pitch, a weak cough, or symptoms of aspiration. People with vocal palsy often have to take frequent breaths while speaking and are unable to hold the air in. And there are several causes of vocal cord palsies. You've got injury to the recurrent laryngeal nerve itself, and this may be during surgery, so things like thyroid surgery or cardiothoracic surgery, or injuries to your neck and chest region, so trauma. You've got things like stroke and tumours, and tumours can affect and cause a vocal cord palsy by either a direct impingement and a mechanical effect, or it can involve the nerve and cause damage that way. You've got infections, so you've got things like Lyme disease, Epstein-Barr, and finally you've got neurological conditions, so Parkinson's, multiple sclerosis. And in many cases, it's idiopathic, no cause is found. So your initial examination, you've got to do a full head and neck examination to think about tumours and other lesions. You want to examine the cranial nerves, flexible laryngoscopy, and flexible laryngoscopy classically shows lateralized, foreshortened, and a flaccid cord. Stroboscopy and electromyography are also helpful investigations. In particular, electromyography can help you differentiate between a vocal cord palsy and a fixation of the cricothyroid joint. Imaging usually consists of a top-down chest X-ray, and that might be your initial investigation, but for a full investigation you need to look at a CT scan. So this is from the skull base to the diaphragm, so you can fully trace the path of the recurrent laryngeal nerve. And an MRI scan is also helpful to look for any local laryngeal pathology. So management depends on the pathology and the level of disability. So in many patients, there is adequate compensation from the other side and their symptoms are very mild, and you do not have to intervene in any meaningful way. Some speech therapy is sometimes all that is required. However, if you have a more profound disability, then you're looking at surgical intervention. So you can use an injection augmentation process, and you can use various materials with various absorption rates, and your aim with all of these treatments is to medialize that cord, push that cord into midline, allow the cords to come together, and that will give you a stronger voice. So injection augmentation is a very good, safe strategy, and it's particularly good in the palliative setting. Other options, you can use a laser cordotomy, and this is something that's pioneered by Kashima. You make a transverse incision in front of the vocal process, and this allows this area to gape open. You get a very good airway outcome, and you it only mildly affects the voice. So you get very mild dysphonia, and there is a low risk of aspiration. Studies have shown that. So that's a good operation, but it is a irreversible process and procedure. The other option is something like a medialization laryngoplasty. So there you go. So this is the Ishiki type 1, and you're looking at medializing the cord through thyroid cartilage, and you can use various materials in there. So there's a block in here, a shim, that can be used, and you've got silastic, you can use hydroxyapatite, Gore-Tex. There's a variety of different materials you use to push that cord through. And again, this is something that is reversible. You can take it out, but often you get a lot of fibrosis around it, so things never quite return to normal. But it's a good operation. This is much more invasive, takes a longer period of time as well. So depending on the fitness of your patient, you can judge and gauge your operation accordingly. Right, so whistle stop through laryngeal pathology, and we're going to penetrating neck trauma now. So we're going to start off with a nice gory picture for everyone, and we're going to talk about a few things here. So there's a few points. So platysma violation. So historically, all wounds that violated the platysma were explored. And nowadays we're a little bit more selective in terms of what we do. So the actual management plan depends not only on the specific patient and the injury, but on the available staffing, expertise, monitoring, and the diagnostics you have available to you. As a general rule, assuming a significant injury has occurred until proven otherwise is a pretty safe approach. You're not going to go wrong there. And often multiple structures are injured as well. Just because the entry wound is in one area, you have no idea often the length of the weapon used and the depth. So often something that looks fairly superficial going in an oblique angle can cause a lot of damage in other areas where you wouldn't necessarily expect it. So there are myriad signs and symptoms following penetrating neck trauma. So we've kind of tried to break it down into an organized structure, and I'll talk about a few of them, but there are many. So for your laryngeal signs, you're looking at things like hemoptysis, stridor. You'll often get subcutaneous emphysema, crepitus, some hoarseness and dyspnea. If you're going for your esophageal and pharyngeal injuries, again, you're going to get dysphagia. Not all of these people are going to be in there wanting to eat, but you can get some dysphagia, you can get pain and tenderness in your neck, and often, again, some crepitus. Vascular injuries, this is going to be either your carotid or your jugular veins. So you're talking about hematomas, major hemorrhage, some pulse deficits, and hypotension. So neurological, you've got injury to the spinal cord itself, which is relatively rare, and that will give you your sort of poor rectal tone, etc. You can get Horner syndrome, and then you can get obviously your cranial nerves themselves. So you get issues with your facial nerve, glosspharyngeal vagus, etc. So some dysphagia, some weakness of your face, hoarseness, and then got your accessory as well. So there's a multitude of symptoms and signs from them. Just try and have a structured approach. Try and build in moving from one area to the other, and that will get you through it all. So initial management of any penetrating neck trauma, it's your ABC, it's your ATLS guidelines. So start working through them all. And from an airway point of view, if you're not sure about the integrity of the larynx itself, then a tracheostomy might be safer than trying to proceed with trying to carry on with intubation. You'd look at having one attempt at intubation or so by the most experienced person there with a smaller tube than normal. But if this fails, then you should move on to a surgical airway. And that can either be an emergency tracheostomy or cricothyrotomy, depending on the situation. And studies have shown that cricothyrotomies are pretty good airways, and they're slightly faster to achieve than tracheostomies, particularly in those who haven't got experience with tracheostomies. You should also consider intubation if the patient has clear stridor. look out for hemoptysis, emphysema, and expanding hematoma. So all of those things would indicate that a patient has an unstable airway, and ideally you want to make a decision about what to do with that unstable airway before the patient starts falling over. If they start falling over, then that's going to limit your options, and it's going to push you into an uncomfortable position. So that's there. So yeah, so traditionally we've used an anatomical zone of the neck type approach to managing, assessing, and dealing with penetrating neck injuries. And this was first described way back in 1969. And it served us well for now. However, more recently, sort of the rigidity of this has been challenged, especially with the kind of mandatory exploration of zone 2 injuries. So this is a paper that talks about what we should do and how things have changed. So we know that routine neck exploration in hemodynamically stable patients leads to a high rate of non-therapeutic intervention. So you missed injuries, increased length of hospital stay, and an increased rate of complications. Lowe et al. Demonstrated in 2014 a poor correlation between the location of the external wound itself and the injuries to the internal structures.
Can you see my teeth?
Right, so this is a simple algorithm from the paper as to how to manage these injuries. And you're starting with your penetrating neck injury and moving down through the flowchart. The first sort of diamond is your selection bit point, where you have to decide if they've got hard signs or hemodynamic instability. And your hard signs are obvious and straightforward. You've got shock, pulsatile bleeding, expanding hematoma, an audible bruit, airway compromise, a bubbling wound in your neck, subcutaneous emphysema, stridor, hoarseness, or difficulty or pain when swallowing or saliva. So if you have any of those symptoms or hard signs, then you move on to securing the airway, tamponading any hemorrhage, and then you go on to surgical exploration. If you don't have any of those hard signs, that would indicate you've got some time on your hands. And in that case, you'd move down to imaging, and you'd look at the CT angiography, and then based on what you find at that point, that will direct you. So if you find a vessel injury or a breach in a viscus, then you move forward to a directed approach and surgery. And if you haven't found any abnormalities, then you could move down and look at esophagoscopy. So, and observing the patient. So this is a much simpler and straightforward algorithm compared to the previous approach. It was the Western Australia Trauma Association have a wonderful flowchart, but it has about 100 different limbs on it and 100 different options to explore based on how stable the patient is and a number of other factors. This is a really simple way of getting to a safe point with the patient and going through and making sure that you have performed all the investigations at the right point. And this is something that I would recommend using in the exam. Some of the examiners may not be, well, they should be pretty familiar with all of this. But I would mention the zonal system and talk about that being present and used in the past, but say that we've moved towards this. And this algorithm, this paper has been around for a good 4 years or so. So it's been around for quite a long time. So I'd hope the examiners would be familiar with it. Right. That's I think that's me done. Thank you for listening. Are there any questions? Is there anything anyone would like to know about?
So that's good. Brilliant. I think the neck trauma is one of the, maybe I would say, challenging station. And please be aware of the new policy changes like angiogram and neurological injuries, pharyngeal injuries, and airway injuries. So multidisciplinary team management involving vascular surgeons, anesthetists, and the theater team, and also the radiologist if necessary, and where to manage, how to manage, the location, these are the key things in terms of neck trauma. And regarding the benign laryngeal pathologies, try to involve like speech and language therapists, risk reduction management, voice clinic, and using other adjuncts before embarking in onto the surgical management. So these are the key things. I do notice when I do viva head and neck, everyone just more keen for surgery. That's fine. The surgery is just to rule out anything sinister, but that's not the cure for most of the things. It's important to understand that one. Good. There's one more from otology. I'm going to play that, then pretty much we are done. So
I'm trying to give you some information about the 7s and the 8s, how you really score highly on some of these vivasations. I'd expect you to know all the basic stuff, so we might gloss over some of that and try and get for the evidence and the sort of the finishing touches, I guess. So I guess you should understand or know that it's a complex condition with 4 major symptoms: fluctuating hearing, fluctuating tinnitus, oral pressure, and vertigo episodes. When you start talking about this in a viva, you probably can touch on the etiology. We don't really know what causes it, so it's fair enough to say that the etiology is poorly understood. That you can touch on genetic causes, allergic causes, autoimmune causes, but there's not that much to talk about there because we don't really know what causes it. The final common pathway of endolymphatic high drops is probably what you should really be talking about, what we do know, that there's good evidence for. If you talk about the incidence, that's difficult to define because the incidence varies depending on which population you study and what your definition for Meniere's is, what you're using as your definition. So the incidence I've seen vary tenfold. I use a sort of in the middle picture about something about 20 and 100,000 as your sort of average of lots of studies depending on what you've looked at. You should know your criteria, so your definite and your probable criteria. You should know that it was updated in 2015. I first did this talk in 2016, so that's why I was playing on it. But the 2015 criteria you need to know. You need to know definite and probable. And if your definite is 2 or more episodes of vertigo lasting for 20 minutes or more, with hearing loss that you've documented on an audiogram, at least once. They will have fluctuating symptoms, whether it's tinnitus and fullness in the ear, and you've not better accounted it for by another diagnosis, so an MRI scan, in all intents and purposes. By the way, if there's anything that doesn't make sense, just shout out. This is quite informal. I've got no problems if you've got a question. Just shout out, stick hand up or something. That's fine. Yep.
So you have to have more than one hearing test. Then?
No. It's nice, but that builds on the probable criteria here, where you've got all the symptoms, but you've not got the hearing loss. You've not captured that drop. Now, if you've documented, so we're doing a multi-center RCT, and they just want to show the hearing loss, whether it's low frequency or just difference from the ears. So in this sort of revision, certain and possible have been removed, so it's only definite and probable. Okay, that's your typical audiogram that you might get as a starter for 10. Talk me through this audiogram, what you see. This is your typical low frequency sensory hearing loss. Okay, your investigation really is your MRI scan. I would do nothing more, and it's fair enough to say I would investigate no further. Lots of people will want to talk about VNGs and calorics and so on. It's not going to provide you much more information because the diagnosis is clinical. The only time you're going to use a caloric or some other investigation is if you're going to do something to the ear, particularly if you're going to do something ablative. for example, intrahepatic gentamicin. I don't think you need chlorix or anything else at all. Of course, if you want to talk about it, that's fine, but you're not going to be penalised, and that you can rationalise it by saying that. Okay. Where you certainly start picking up the points is going to be on ladders of treatment and evidence for the investigations or the interventions you're going to offer. So I'll talk about the evidence in a minute. About this is your ladder of treatment. The wrong way around. So you start at the top and work downwards, or work the bottom and the top. So you start with dietary modifications: salt, caffeine, alcohol. The evidence for those is poor, but that's what you pretty much all of us will try and talk about. Okay. Oral medication, beta-histine diuretics, many people will already be on that. I'll talk about the evidence for that in a minute. Next layer would be intratympanic therapies, steroids or gentamicin, and this really has become my first-line treatment now. Intratympanic steroids is pretty much my first-line treatment. Beyond that, a little bit more intervention, a grommet, plus or minus a Meniere device. Any of you come across or heard or used or seen some use a Meniere device? Positive pressure is the other thing that people call that. It can work. We've got 2 people in TASER with it. The evidence is pretty average again about it, but I'll show you that in a slide in a minute. Next layer, a little bit more intervention again, intratympanic gentamicin or endolymphatic sac decompression. And then at the top, if you like, labyrinthectomy or vestibular nerve section. So that's your basic ladder or sort of scalability treatment. What you've always got to think about, and it's worth talking about sometimes, is bilateral Meniere's disease. So if they've got one, if you're going to do something ablative to one ear, you've always got to think about what's going to happen in 5 years' time, 10 years' time, if they develop it in the other ear. So that's why we're pretty much now ultra-conservative and trying to avoid anything ablative, because we've all seen problems with somebody getting it in the second side. I've certainly inherited lots of people with labyrinthectomies done in Dundee over the last 20 years, and now I'm a bit stuck because you can't do much for you. You're a bit limited. So this is your kind of evidence summary, and it's really nice. Many disease has lots of Cochrane reviews. So if somebody tells you why you're doing that or why you're not doing this, it's great to say, look, there's a Cochrane review on this, and the reason I'm doing this or the reason I'm not doing this is because the Cochrane review says it's great or it's not great. So for beta-histine, there's insufficient evidence that it works. There are lots of trials, mostly are inadequate, but some suggest a reduction in vertigo. There's a particular trial that I'll talk about on the next slide, which is really useful for you. Diuretics, again, the Cochrane review says there's insufficient evidence. Intratympanic steroids, the Cochrane review supports that. So there's good evidence or decent evidence for that. If it's good enough for Cochrane, it's good enough for us. Okay, so there's good evidence that works. Intratympanic gentamicin, again, 2 trials demonstrate that it works. So this is where your evidence is starting to rack up with that sort of level of treatment. Endolymphatic sac surgery, insufficient evidence, a couple of trials on it, but as with most Cochrane review, surgical studies don't do very well today because it's difficult to properly randomise and blind. Positive pressure, 5 trials in the Cochrane review, but insufficient evidence to say it works. So this is really quite a nice chat to have for your examiners. It's worthwhile mentioning this RCT in beta-histine was published early 2016, I think maybe 17. Michael Schrupp was a neurologist in Munich who was dead keen on high-dose beta-histine. He published lots of papers saying this really high dose to beta-histine is brilliant, it's safe, it works really well. Then they designed a perfect RCT, so high dose, low dose, and placebo, and the outcomes were exactly the same at 9 months. So we can infer it is actually a placebo. Now, it had a 40% response rate. Great. So that's quite a big placebo rate. But if you're aware and you're comfortable with you giving a placebo, that's fine. Beta-histine costs about £2 a month. It doesn't really have many side effects. So as a placebo, it's quite useful, quite a good thing to use. You just got to be aware of it. So another good study to quote is the London RCT, where they compared gentamicin and methylprednisolone given at 2 weeks. Both had a close to 90% response rate and no difference secondary analysis at 24 months. So that tells you there's not massive benefit in using gentamicin over steroids, and the side effects are obviously much less for steroids. So that's become our frontline, sort of first-line treatment because of this study. Is that okay for everyone? Yeah. Indications for surgery. If you're getting onto this, you're doing great in your Meniere's, viva. I would say it's pretty unusual because the success rate of steroids or gentamicin being 90%, you're going to have only a few people who are ever going to get to this level. And your two options in that circumstance would be a labyrinthectomy. That will get rid of the dizzy attacks, but it's going to cause imbalance and they're going to lose the hearing. Or a vestibular nerve section, you're going to get rid of the vertigo, they're going to lose their balance, but you're hopefully going to preserve their hearing. Again, in that circumstance, it's very worthwhile mentioning the difficulty in managing the second side if it ever comes to it. So you want to be very selective about offering that. You certainly wouldn't want to be going straight to numbers. Any questions about Meniere's disease? No? Okay, otosclerosis. Worthwhile talking about the genetic etiology. There's London and Oxford, I think, are maybe studying this at the moment. So we know there's an autosomal dominant inheritance pattern with variable penetrance. There's a couple of genes that have been recently isolated in the UK. So again, it's worth having that in your back pocket if it comes to it. We know that measles is involved somehow. We found mRNA in the stapes and antibiotics in the perilymph. But we've all either been vaccinated or have had measles. So we don't really know what role it plays, but it's definitely involved in some way. It might be worth commenting on that it worsens during pregnancy, and women should be aware of that. So typical diagnosis is going to be conductive hearing loss with this audiogram. You should really be able to describe and explain what a Carhart notch is quite comfortably. You will probably normally see a normal tympanic membrane. We've got this odd, occasionally you get a Schwarzer sign, but that's going to be pretty unusual. Normally you're going to have a normal tympanic membrane. You should be able to explain acoustic reflexes. If you can't, we can talk about that tomorrow or next day, or there's audiologists here who again are going to be able to talk you through very clearly acoustic reflexes, so you've got that in your head. Vertigo, you can ask about that. It does happen quite commonly. We don't know why. Maybe related to Scarpa's ganglion degeneration, but it's quite a common finding in otosclerosis. You should know that tympanometry is normal. Speech audiometry, we like doing that. Many centres like doing it if you're going to operate on somebody, so speech audio is quite a useful thing. So again, having seen some speech audio, have you all seen some speech audios? You're happy looking at them and talking about through what it is. So again, if you've not, then there'll be some audiologists here tomorrow that you can look through these things with. So just be comfortable if somebody's going to give you one of these investigations, or you're going to ask for these investigations. I'd like to get reflexes. Be prepared to talk about what you're seeing. Okay. On this CT scan, I suppose that's a little bit controversial. I wouldn't say it's standard investigation. Some people would say it's a standard investigation for conductive hearing loss. I don't think you're going to be penalised by not saying it, but if you do want it, you might get given one, and therefore you should be able to find the abnormality. Okay, so the abnormality, if you can see that there, is this little lucency here, this little dot at the front of where the Sebi's footplate here, and again here. So that's a lucency at the fistula antifenestrum. What's another good reason to scan in this condition? Cochlear involvement, okay, yeah. Facial nerve position, that can be quite tricky, and just in these sort of scans, but some people do it for that. Perilymph pressure, somebody said, that's good, yeah. So you can get that in X-linked disorders, can't you? So X-linked deafness. Sometimes you can get clues that there's going to be a gusher. The other one I've been caught out on is a supracanal dehiscence. So when somebody's had an apparent conductive hearing loss, and they mentioned maybe not given all the classic symptoms, but they've had a supracanal dehiscence. So that's the other one that can cause an apparent conductive hearing loss with normal tympanometry traces. So your management should be watch hearing aids and wait for a few months to see how they get on with that. That pretty much should be your standard conservative. I'm not going to rush in on surgery on this sort of patient. Fluoride certainly could be used if somebody's got a progressive sensorineural hearing loss. That might be something you want to consider and know about. The evidence isn't great, but that's be something that they might talk about if you're getting to the end of your otosclerotic viva. Bone conduction devices or BAHA certainly would be an option, and in some centres that would be what you're getting for otosclerosis. So a risk-averse surgeon would give you a BAHA. Many times you'll come on to staphylotomy and staphylectomy and have to talk about the consent process, how you're going to do the procedure or what you're going to consent to before. Staphylectomy is not a day one surgical operation, but to be able to talk about the pros and cons and the risks certainly is. They might ask you what the rate of decline is. That's the rate of decline. I usually say about 1 decibel in bone conduction and 1 decibel in the air-bone gap. So 2 decibels per year deterioration, or 1 decibel in the air-bone gap. So that's 10 decibels in 10 years. So often you wait, don't you, until somebody's flipped their release negative. So you might want to wait until there's about a 20 decibel air-bone gap before you operate. So you can sort of prognosticate that that might take 5 years or whatever, if you've got a 10 or 15 decibel air-bone gap. Okay, so fluoride, 50 milligrams, I think, is the dose. I think, but there's no level 1 evidence for using it. But that's the one thing you could probably consider. Okay. Come on to surgery. So the complications, you need to be able to talk about chordae tympani injury, and the fact that it's usually short term, but there's probably a couple of % have long term chordae tympani symptoms if you divide the chordae tympani. You need to be able to talk about dead ear risk, vertigo, reparative granuloma. Some people will get, I know there's some vivasations where people say they come back 10 days later with dizziness and notice worsening hearing. And you need to be able to talk about these sort of complications in that circumstance and what you're going to do about it. We should know that your target outcome is going to be air-bone gap closures less than 10 decibels, and you want to be achieving that in 90% or greater. That's going to be your target. It's obviously not always going to be achieved, but that's what you're going to be wanting to consent somebody for. That should be the figures. Okay, lastly, if we just touch on auditory implants. Again, we'll have a few for you to look at tomorrow. Most of you seen these sort of things? Yeah, most of you in centres where you're going to Birmingham, I believe, are you? Yeah, so you're going to get them because they have a big Baha program there. They have middle ear implants. They have quite a lot of funky new implants as well. They certainly have cochlear implants. So you should be able to be fairly confident with these, both in your viva, but particularly in clinical. So we need to talk about indications. We need to talk about the types of bone conduction devices that are available. We need to talk about semi-implantable devices. When I say semi-implantable, they've got an external processor, but they're sort of under the skin. You might come across single-sided hearing loss patients, either in the clinical or in the viva, and probably complications. I'll just touch on that. So I divide my indications into patient factors and audiological factors. So there are patient criteria that they need to meet and audiological criteria they need to meet. For a patient, it's pretty much they can't wear a hearing aid. Whether it's because they've not got an ear, they've got an open middle ear, they've got a tight externa, or whatever. They can't wear a bone conduction, a standard BTE aid. Your audiological indications will vary depending on the implant that you're going to offer. So these are broadly, if you've got a conductive and mixed hearing loss, you're going to get any of the above. But your bone conduction threshold has to be 45 dBs or better. There is a bit of a slope to it, but if you use 45 dB as your benchmark, then you should be okay. These graphs on the right are the Med-L criteria for Baha and bone bridge at the top and the vibrant sound bridge at the bottom. So for sensorineural and mixed hearing loss, you can offer a vibrant sound bridge, and that's this criteria here. Now this is the air conduction, not the bone conduction. This one, you're looking at the air conduction. On this one, it's the bone conduction. Okay. And for single-sided deafness, you can't offer a VSB because that aid doesn't work, but you can offer a bone conduction device, so a Baha or a bone bridge. And on that, you really want the bone conduction thresholds in the contralateral ear to be 30 or better. You can get away with a little bit more nowadays with superpower Baha, but 30 or better is really ideal.
The sound bridge is the one that clips on the optical.
Yeah.
The one that hammers on the
That's right, yeah. So bone conduction, broadly, is the oldest system available. They are relying on direct stimulation of the cochlea, so via bone conduction straight through here into the cochlea. Two manufacturers, Cochlear and Oticon. Lots and lots of people have them. You can't guarantee anything like, but you're very likely to see them down there in Birmingham because they started the program really early. They have a lot of people with them. You could probably talk about the advances in the surgical technique that have been happening. Back in the day, it was thin the skin out, make a wide bed, if you like. We've moved away from that. There's now minimal soft tissue reduction and just drilling the bone straight in, early loading of the implant after 3 or 4 weeks, and often it's a local anesthetic procedure. You should probably, have you heard of Holger's skin reactions? Yeah, some nods, yeah, it's good. That's what we use as an outcome measure. So up to 2 was considered a good outcome. That would be acceptable. 90+% of patients will probably have, well, 85 to 90 would have one of these scores. Not a good outcome would be 3 or 4. I think overall the figure of implant loss in bar heart is about 8%. That's obviously higher in kids, even higher in kids with syndromes, but overall your figure will probably be about 8%. So that's implant gets so infected or actually falls out. That's big series. That can be, so you can sort of work around that by using a bar heart attract. But bar heart attract has problems as well because you're using a magnet to squeeze the skin, and therefore you can get some skin necrosis, and you get some attenuation through the skin. These are some pictures of complications of the bar heart attract from Toronto, I think. But again, that's just a variation of a bone conduction device. I think you're going to probably see these in pediatric cases. You need to be able to talk about the conditions that can be involved here, Treacher Collins, Down syndrome. And if you get a case like that, you want to be talking about the quality of the bone. So it's going to be poor. There's going to be much more likelihood of skin overgrowth. Complications in children up to 20%. So 1 in 5. That's why parents need to be counseled a lot on cleaning and the risk of trauma. Children go and bump their heads and it falls out. So they've got to be really a bit careful about this. And that's why many surgeons will offer 2-stage surgery. So put the screw in or put 2 screws in, cover them up, and then come back 3 months later and allow a second, then put the abutment through so the bone, so that the screw has osseointegrated. So it's really taken. Whereas in an adult, you're going to get a single shot procedure, you're going to get your implant after 3 or 4 weeks. So it's just that subtlety of differences, okay? Vibrant sound bridge. So this is the one that you mentioned there. This is where you get direct drive of the ossicular chain. You have a variety of ways of attaching this onto the middle ear. So this is the 2nd generation device. These are little flanges to hold the processor in place. This is the coil, and this is the little business end. This is the FMT, floating mass transducer. And this little thing can be attached onto a variety of bits of the ossicular chain. This is the short process coupler. This is probably the easiest and sort of first choice approach if you can get it. It can be attached onto the long process down here. If you've not got an incus, it can be attached onto the stapes. And if you've not got a stapes, it can be attached onto the round window. And that's probably your order of preference of insertion, A, because of ease. There's a little bit of data to suggest that a long process coupler, so having it vertically here, provides greater gain than it does here. That would probably make sense, but you're only talking a couple of decibels. So it's probably not worthwhile going for the greater procedure, posture tympanotomy and so on, if you've got quite an easy procedure here, unless they're right on the limit of the criterion. Okay. This would be a fairly typical clinical case. I realise the audiogram here is the other way around, but he does have bilateral hearing aids. So if you zoom in, he's got a bit of an otitis externa here. He had trouble wearing hearing aids, this is a 1st generation process. So this is what it looks like. You might get a kid with a scar and a process from the back, and then you'd probably want to look in the ear and talk about the sort of conditions he may have had. The audiogram here just shows a unilateral conductive loss. Obviously, it's the wrong ear for this picture, and I apologise for that. But this sort of hearing loss You could pretty much get away with any of the implants, couldn't you? Yeah. Bone conduction better than 20, 25. Air conduction here around about 45. A little bit of high frequency loss here. So the sound process, the vibrant sound is probably better for this high frequencies, but that's really just the small. You can pretty much get away with any implant for this type of hearing loss. So this is the bone bridge. This is implanted in the bone behind the skull. Very similar in fact, the same technology, just scaled up. So the technology in the floating mass transducer is the same as in that. This just vibrates up and down. These screws attach onto bone, and the whole thing vibrates in a well, and that just uses bone conduction. Okay. Same criteria as for Baha, so better than 45 decibels across the board, but better than Baha probably because it's got no wound, better cosmesis, less complications. The downside of this, it's quite bulky, so it's difficult to get into children, and some adults will feel discomfort and pain because it's quite a big device. Sorry? Loosening? No, the problems we've had have been infection, as with any implant. So we've had a couple of explants. Looking at, there is data from most centres have been submitting. There's not much on loosening, no. Okay, so this is an example of a clinical case you might get. You might get a atretic ear with going bilateral conductive hearing loss. And the issues here you want to talk about are going to be patient and audiological. Audiological is good for everything. Patient, you're going to have to consider they may want to have auricular reconstruction down the line. So sticking a dirty Baha on the outside may not be the nicest thing if you're going to want to go through multiple procedures for more cosmetically acceptable ear. So this is where the bone bridge or the sound bridge are useful. And then you really got to look at the middle ear quality. So what's available? Is there an incus? Is there a stapes? Is there a round window? Can you get there? Where does the facial nerve go? And so on. So you're talking about, what's the criteria? What's it called? Yarsdorfer? Middle ear? Yeah. So you're looking at, if you get into that, you're doing great, by the way, but if you want a CT scan and to assess what's going on in the middle ear. More and more centres are going for a bone bridge in these circumstances. Just because it's easier. Have you seen the ad here, anybody? Some nods. So this is an adhesive device. You can see here, this is stuck on the back, onto the mastoid bone, and this works just like the others. It vibrates away, and if you've got very good bone conduction, but a good bone conductive hearing loss, this is a really good solution. We've used it in kids, we've used it in adults perioperatively, when they don't really want to wear a headband, softband, for example. Here, this sort of classic one, you've got a bit of a tight sterna here, and you've got this on the back. So this is quite a nice, sometimes permanent. It's only been out for a couple of years, so we don't really know if it's going to be permanent, but it's definitely a good perioperative measure, or for short term, we've used it and we quite like it for that. Probably works as a trial as well, as a sort of take this away, use it for a couple of weeks and see what you think. Yeah. I'll come on to that. You mean for that one? Is it good enough? We've not used it for that. I guess theoretically you could use it if the other side was perfect. Yeah. I don't think we've used it for that, but it should do. It should do. You're going to get a bit more attenuation, but if the other side's good enough, then it should be fine. So single-sided hearing loss, useful to talk about. Why do you get it? Sudden hearing losses or vestibular schwannoma, either preoperative or postoperative, for example. Problems they're going to get are going to be hearing and background noise and sound localization. Most of people with that problem adapt and just cope with it. Maybe it's because they've been through an awful lot of surgery to get there, who knows. But only about a quarter of patients with a VS take up the offer of an implant for single-sided hearing loss. And about a third of people with a sudden sensory hearing loss as an adult take up the offer of an implant. So it's a pretty low, small group of people. That might be patient factors, that might be occupational factors, things to talk about, you know, these are the issues. One route of getting through a single-sided hearing loss viva is trying a cross-aid. Non-invasive, simple, cheap, and if they like the sound but don't like wearing 2 hearing aids, then we usually step them on to an implant, and then a bone conduction or a Baha would be a bone bridge would be the options of choice there. Again, it's another quite a good one for a clinical case. I think I remember that going on when I was there. Okay, so that's me about half an hour. Any questions on those 3 subjects? Yeah.
What's the audiological criteria for a bar?
Perhaps that misunderstood.
I think that's it really.